COVID-19, Aerosolization and Droplet Contamination during Pleural Decompression, a clinically relevant study by the NTRI, National Trauma Research Institute, and Alfred Trauma Service. COVID-19 first emerged in Wuhan, China in late 2019, and a global health emergency was soon declared. With millions of infections and deaths worldwide, the effects are crippling. In Melbourne, we may have been spared the horrors of Lombardy and New York, but we see the effects in our economy and community. Quickly rivaling the Spanish flu, COVID-19 will continue to protract, and there is a need to be prepared. The primary mode of transmission is thought to be via droplet transmission, as well as fomite contamination. Of interest in our study is the potential of airborne transmission and risks to healthcare personnel. Transmission of respiratory infections can be categorized into droplet or airborne transmission, with droplets falling between 5 and 10 micrometers, whereas aerosols are less than 5 micrometers. Droplet transmission occurs when an infected person produces respiratory droplets, through coughing or sneezing. However, aerosol transmission can occur when air moves quickly over a layer of fluid, and small particles can persist in the air, especially in crowded and poorly ventilated spaces, such as resuscitation bays in an emergency department. As a busy trauma centre, we were interested in the risks of COVID-19 transmission from pleural decompression. Despite being a common procedure done by surgeons, trauma and emergency physicians, there is a huge absence of data on the risk of aerosolization from this particular procedure, which lends itself to the detriment of the proceduralist. Hence, our primary aim was to investigate if droplet contamination occurs that is not immediately visible to the naked eye, which might further lend itself to the plausibility of aerosolization. And within that, our secondary objective was to determine the adequacy of recommended currently used PPE for pleural decompression at the Alfred Hospital. Ethical approval was gained. We investigated this by simulating viral droplet contamination using the chest decompression trainer from Limbs and Things. This mannequin is an anatomically accurate representation of the adult male torso, and its design includes bony and soft tissue landmarks, as well as accurate internal anatomy. The internal reservoirs can also be pressurized to provide a realistic release of air upon decompression of the pleural space, which is integral in this setting. Fluorescein was used to identify droplet contamination and has been used in the past in virology to map contamination and aerosolization. To simulate a tension hemopneumothorax, the mannequin's hemithoraces were filled with approximately 1 litre of red-dyed water, 2 ml of 100 mg per ml of fluorescein, and about 500 ml of air. The proceduralist was a Royal Australasian College of Surgeons Fellow, wearing the currently recommended PPE as pictured, which included an N95 mask, a face shield visor, a surgical cap, long-sleeved surgical gown, and gloves. The mannequin was placed supine, as most of our trauma patients would be maintaining full spinal precautions, and then were square draped. A standard open cut-down technique, used by the Alfred Trauma Service, was employed to decompress the right pleural space, as shown on the left, which is a cadaveric demonstration. A skin incision was made at the 5th intercostal space, anterior to the mid-axillary line, and blunt dissection was carried out down through the chest wall, and the pleural space was entered with a hemostat. A finger thoracostomy was performed, and a 28 French ICC was then inserted into the right pleural space. The procedure was filmed and photographed in normal lighting and under blue light to assess fluorescein droplet contamination. As can be seen here, there is clear splatter and droplet contamination of the proceduralist gown upon entry into the pleural space. Post-procedure, areas of red fluid were visible on both gloves, the right dominant forearm and waist of the gown. There was no visible contamination to the head, neck or chest of the proceduralist under normal lighting. However, under blue light, droplet contamination not visible to the naked eye was now visible extending onto the visor, both shoulders and chest. This re-emphasizes the extreme caution required when performing pleural decompression. Appropriate PPE, as described, especially a face shield instead of goggles, and impermeable dress should be worn. Our Alfred staff should advocate for the use of buddy surveillance while stuffing PPE post-pleural decompression, to reduce the risk of self-contamination. In conclusion, our simulation demonstrates that droplet contamination to the proceduralist occurs during pleural decompression. It is highly plausible that aerosolization occurs as well, though this may not be visible to the naked eye. There appears to be no other studies to date reporting on the evidence relating to this subject. In terms of limitations, we understand that this is a simulation model, and the dispersion of micro and nanomolecules would be better characterized with the use of a scanning electron microscope. Thank you for your time and consideration.